This is the ruptured cyst abscess with a minimal scar. Let's get into it. What's up, everybody? I'm Dr. Galliani, and today we have this ruptured cyst on our patient's back. Now you can see how inflamed it is. The patient actually has had it for a while, and currently it's not very painful. But I'm doing these videos not just to show you the cysts and everything else, but I want to educate people about other things like skin cancers. Now, this was a squamous cell carcinoma on his temple. It is extremely important to recognize the features of skin cancers. These growths are growing fairly rapidly, hard, scaly sometimes, wounds that don't heal for squamous cells and basal cell carcinomas. And then for melanomas, they can be just moles, flat moles that are changing shape and color. And they can come in all varieties of color, from brown, black, blue, to even pink. So if you see something new that's not going away, growing pretty rapidly, make sure you see your board-certified dermatologist as soon as possible. So let's get into the video. All right, you feel a little needle poke here. Have you seen a pore yet, Mallory? Mm-mm. I haven't seen a true pore yet. Maybe in the middle there. How are you feeling?
Okay.
Okay. So we're putting lidocaine with epinephrine. At first, just plain lidocaine here to numb up the area. You've probably heard this if you're watching these videos. You know, when the cysts are inflamed, they're acidic, and it changes the acid base in the skin. And so lidocaine is a base, a weak base, but when it's in the solution, in the preservatives that they put in, it makes it quite acidic. The skin has a pH close to 7, close to a neutral pH. And actually, lidocaine works the best at that neutral pH. So when there's inflamed tissue and makes the skin very, very acidic, the anesthesia doesn't work as well. All right, a little pressure here. Definitely a ruptured cyst. There's just a lot of pus in there, but it's coming out. Now, these cysts are as fun as to do as it is to watch. They're pretty satisfying. Not only do the patient get a lot of relief and improve of their symptoms and their pain, but they're just fun to do. A lot of times these cysts have different little loculations, like little pockets. Yeah, sometimes a lot of these cysts have multiple different pockets in there, and so I like to press in different directions and move the skin around to try to get to all of them. And sometimes you use a curette to kind of break down the adhesions. Personally, I like to use pickups and some scissors, very sharp scissors, to remove some of that scar tissue that I see. A lot of times the cyst wall is kind of just attached like wallpaper to the surrounding skin, especially to the dermis. And a curette is not going to do the job by just scraping those edges. You really have to kind of cut that scar out. So I grab the pickups and I cut them out.
Good. Okay, great.
So a lot of time, this is all done by feel. You're
just a little harder here because there's some.
Yeah, so I'm feeling the skin, and I feel like there's a little bit of a bump underneath the skin. So I want to make sure that that's all out. Sometimes it's just swelling. Sometimes it's just actually the anesthesia that we put in there makes it feel more bumpy in there. So I'm squeezing, I'm pushing, I'm just trying to make sure that everything is flat. and then in a second I'll grab those scissors and kind of clean out as much as I can. Now cysts, again, cysts happen because of either a clogged follicle, sometimes trauma, causes the top layer of the skin to get embedded underneath the skin, and that layer of skin is actually making new cells. And as those new cells grow, they push out the old cells out, and the very top layer is actually just dead skin cells. Everything that you see on your skin, the top layer is all dead skin cells. But on the surface of your skin, it just sheds off into the world. However, inside a cyst, it collects inside that pocket, and it keeps growing and growing until eventually in certain areas it just ruptures, it breaks down. And when that cyst breaks, the keratin, the dead skin cells, are not supposed to be outside of that confined follicle or that cyst. And your immune system feels like it's being invaded. It feels like there is a foreign body in there, which it is. It's a foreign body to the surrounding tissues. And so the immune system comes in, the white blood cells come in to try to clean out, dig out, get everything out and push everything out. So you have increased circulation, you have swelling, you have pain, pushing everything out, pus. And it's just trying to get everything out.
That wall just got chewed up by your immune system.
On the back, the skin is so thick that sometimes it can't quite make it through the surface and it doesn't rupture. And then your immune system takes care of it and the inflammation comes down like it did for this patient. He wasn't really having that much pain, but there was a lot of pus in there just sitting there. And it's just not going to heal properly that way. So we have to drain it. We have to open it up, drain it, get everything out. And a lot of times your patients are going to need another surgery to have this completely cut out. Because if any piece of that cyst is left behind, then it's just going to grow back. So, and these, to do it right, it takes a little bit of time. I try to do my best to make sure that we get everything that we see. And sometimes this cyst doesn't come back, and the patient doesn't need a surgery. So there's no need to do a surgery just because. So I tell a lot of my patients, we'll drain this out, give it a little bit of time, let it heal. If you feel a bump, any inkling of a bump coming back, call me before it gets painful, and then we can do a proper surgery to remove that cyst. I think it's pointless to do a huge surgery to remove just scar tissue. It's going to cause a bigger scar. Sometimes it doesn't heal well. So I tell patients, just give it a little bit of time, see what it does, and then we can get the whole thing out. So these pickups that I'm using are called bishops. They're super small. I love them because I can really hold on and grab the things that I need. And then I use these real small scissors to cut, sharp scissors to cut around that scar tissue.
Definitely some bruising just from the pressure that we did there, but the swelling and everything will come down. There is a little slit, like a paper cut that goes deep into that tissue. That's just going to heal from the inside out. We don't need to pack it or anything like that. All I want you to do is change the dressing every day, and I'll see you back in 2 weeks to see how this goes.
So yeah, we do not need to pack these wounds. I tried, there's no real necessary for something that small to pack. Just removing that abscess and the pus and the dead skin, all the contents is enough to have it heal. And before I make an incision, I try to put it in the normal resting lines of the skin. And on the back, right in the middle, it's vertical. So you can see on his picture that he had a previous doctor or somebody cut out something on his back, and they cut it out horizontally. And that scar just spread. It looks terrible because they did not place that scar within the normal resting lines of the skin. It should have been more vertical. And so you can see here now, 7 days later, or 2 weeks later, our incision where we try to just make that slit is nearly invisible. There's no spread or anything like that. It's closing pretty nicely, and that's going to disappear. So proper placement, even when you do these incisions for abscesses, is crucial. So I hope you like this video. Make sure you subscribe, like, and comment, and I'll see you in the next video.